have stuck with us this far, and I am going to present the last half hour, which is on Medicare 101 and the Medicare Fall Open Enrollment. Next slide, please. So we'll talk a little bit about the history and general structure of Medicare, because that sheds a lot of light on both the choices you face and sort of the gaps that are present in Medicare. We'll talk about some specific considerations for people with bleeding disorders to consider as they become eligible for Medicare. Honestly, as people on this call know, it is really only recently that we in the bleeding disorders community have had a lot of people age into Medicare eligibility, and that is because of the terrible toll the bad blood crisis took on our community. So the fact that we finally have sizable numbers of people aging into Medicare is an awfully good thing, that has required those of us on the policy side to educate ourselves. Next slide, please. So Medicare is health insurance for seniors, but it's also for some people with disabilities and with specified illnesses. And it really is very popular among its users, particularly, again, for those of us in the bleeding disorders community. We may have spent some decades just struggling to maintain coverage, certainly before the Affordable Care Act, even after the Affordable Care Act was passed. It has been, never far from top of mind that we had to work hard to maintain that coverage. Now you turn 65 and you are eligible. It can't be taken away from you. But Medicare is complicated. And again, that's due to its history and to its structure. It's almost 60 years old now, and even that, when it was founded or established in 1965, that marked the culmination of decades of work. And in 1965, Medicare, was really intended to provide coverage for hospitalization and acute illness. Medical science, frankly, was not where it is today. So now, almost 60 years later, Medicare covers over 60 million Americans, but it also covers a lot of preventive care, chronic condition management, and things well beyond the hospitalization context. And it does so, we talk about Medicare as one program, but it's really a couple of programs all under this one, umbrella term of Medicare. But that fragmentation, the several distinct programs, does create some complexity, and it creates some gaps in coverage. Next slide, please. So Medicare has 4 parts, each denominated by a letter. Part A is basically the hospital services. It's hospital inpatient care. It's also skilled nursing facility care, SNFs, which had been a policy priority for the bleeding disorder for some time. Part B is outpatient care and medical services. So it's doctor and specialist care, it's labs and diagnostic tests, it's durable medical equipment and supplies. That could be a wheelchair or something like that. It's ambulance services, and very, very key, it is certain drugs, Part B drugs. They're typically thought of as doctor-administered drugs. So injectables are covered under Part B, as in boy. And that includes bleeding disorder products. It includes clotting factor and other bleeding disorder injectables. Again, thought of as doctor-administered, even though we in the bleeding disorders community know that most in our community administer the drugs to themselves at home, but they still fall under Medicare Part B. I'm going to skip Medicare Part C because we'll come back to it and talk about the Part D benefit. This is kind of the youngest part of Medicare. It's only about 20 years old, because until this century, Medicare did not have a prescription drug benefit. So the Part D was enacted to provide coverage for prescription medications. And again, these are typically drugs that you would pick up at the pharmacy counter. It is not your bleeding disorder products. And Part D in Medicare may be a standalone plan, or it can be integrated with a Medicare Advantage plan. We'll dive into that in the next slide, or coming slides, but we can move forward. So getting started with Medicare, some people will get Medicare automatically. If you're getting Social Security, you will get Medicare automatically. But if you are 65 or nearing 65 and not yet getting Social Security, you may have to take proactive steps to sign up. There will then be certain times of the year when you can change how you get your coverage, or if you miss that window where you can sign up for coverage. And we can go to the next slide. We'll cover these points in coming slides. So when you get started with Medicare, your first decision point is really deciding how you want to receive your coverage. Do you want to go with original Medicare? That's going to be the path marked out in yellow on the slide. You get original Medicare, which is the Part A hospitalization and the Part B medical outpatient. And then you're going to, and we'll talk about why, you're going to add a Medigap plan for supplemental coverage and a Part D prescription drug plan. Or, going back to that initial decision point, do you want to go with Medicare Advantage? That's that Medicare Part C. That's where you choose to get your Medicare benefits through the vehicle of a private Medicare Advantage plan sold by an insurance company. And the Medicare Advantage plan will combine parts A, B, and usually D into one. Next slide, please. So what does original Medicare look like? Again, it's Part A and B, hospitalization and outpatient doctor services. We'll talk about the costs and coverage. We'll talk about where those coverage gaps arise and how to fill them. So next slide, please. Nope. Next slide. There we go. So there are premiums in Medicare and there is out-of-pocket spending. So as and those thresholds change every year as we enter 2023. The Part A premium for most people is $0. If you worked for 10 years or you're the spouse of someone who worked for 10 years, it is assumed that you paid into the system, and so you pay $0 premiums for your Part A coverage. But there are deductibles. There's an annual deductible for hospitalization of up to 60 days in a given year, and then the deductibles start mounting very rapidly for longer hospitalization. Similarly for SNF stays, the skilled nursing facility stays. On the Part B side, for the medical or outpatient services, most people will pay a monthly premium of about $165. Something to note, that is actually lower in 2023 than 2022. That almost never happens, but Part B premiums and deductibles are modestly lower in 2023 than they were this year. A small number of higher income enrollees will pay more than the basic $165 monthly premium. There is an annual deductible for Part B services, and some doctors can charge more in coinsurance. But the key thing that I really want to hammer home for a bleeding disorders audience is that there is coinsurance of 20% under Part B with no maximum cap. And again, remember, your clotting factor or other bleeding disorder medication is under Part B. And almost no one in the country can afford 20% coinsurance on the cost of their bleeding disorder drugs. Next slide, please. So that is definitely a gap. That substantial out-of-pocket exposure, including for long-term hospitalization, where again, for the first 60 days of hospitalization, there's a flat $1,600 deductible, but then it starts going up by $400 and then $800 a day. No one wants to think about being hospitalized for more than 2 months, but you really don't want to think about being hospitalized for that long and paying that kind of money. But also the open-ended, uncapped Medicare Part B 20% coinsurance that is unsustainable for anyone who uses bleeding disorder products. Another gap in original Medicare that's been much in the news is that there are no hearing, dental, or vision benefits. There is an effort in the last Congress to try and pass a law to change that. It did not succeed. So under original Medicare, that is a sizable gap for some people. And under original Medicare, you need separate coverage for prescription drugs. And so the way to fill these gaps, the out-of-pocket exposure and the coverage for prescription drugs, means that anyone with a bleeding disorder needs supplemental coverage and they need a Part D prescription drug plan. Next slide, please. So what does that supplemental coverage look like? It's also called Medigap. You may have heard the term Medigap. These are plans that protect against that open-ended, potentially very burdensome cost sharing in original Medicare. They are, again, sold by private insurance companies, and they supplement original Medicare A and B. They really are the only way to get comprehensive hospital and outpatient coverage within original Medicare, including nearly 100% coverage for your Part B bleeding disorder drugs that are so essential. Medigap policies come in 10 standardized plan designs. So if you get a Part F plan, it will cover the same things, whether it's Aetna or United Healthcare. And their Medigap policies are guaranteed issue during your initial window of eligibility. So when you first become eligible for Medicare, you can get a Medigap supplement and you can't be denied because of your pre-existing condition, and you can't be charged more because of your pre-existing condition. Those protections evaporate pretty quickly once you're outside your initial window of eligibility. There are some things that Medigap policies don't do. They are not compatible with Medicare Advantage. Remember that Medicare Part C? I keep saying we're going to get to it. We are going to get to it. You cannot combine a Medigap policy with a Medicare Advantage plan or an employer union plan. Medigap policies don't cover couples. So if you and your spouse are both eligible for Medicare, you may each need to get a separate Medigap plan. You will not be covered by the same plan. Medigap policies don't fill that gap for dental, vision, or hearing, or for long-term care. And they generally don't cover Part D prescription drugs. Again, those pharmacy counter drugs. So you're going to have to go elsewhere for Part D prescription drug coverage. Next slide, please. So then you have to add yet another plan, a Part D prescription drug plan. Now, each Part D plan is going to come with its own formulary and different price points. Remember, in our first presentation, Louise was saying for ACA insurance, when you do your research, you may find that different plans formularies cover some of your drugs, but not all of them. That is true with Part D prescription drug plans too. And so you have to do some research, and the formularies are available online. Again, bleeding disorders injectables are not covered under Part D. They are covered under Part B. And so you may think, well, do I need a Part D prescription drug plan? And the problem is, you may be a rare person who gets to 65 without taking any pharmacy counter drugs. But if you anticipate ever requiring additional prescription drugs, whether it's blood pressure, whether it's heart pills, whether it's thyroid, then you need Part D coverage as well as Part B for your bleeding disorder product. And once again, you generally have to sign up for Part D coverage when you first become eligible, or you risk paying a penalty in the form of higher premiums for the rest of your life. Next slide, please. So there are some changes coming for Part D prescription drug plans, and these are all really good news for consumers. The Inflation Reduction Act, which Louise has talked about, limits beneficiary out-of-pocket spending on Part D drugs, but some of those limits get phased in over time. Effective in January 1 of 2023, really good news for people who are diabetic and require insulin. Starting on January 1, people with Medicare Part D who take insulin will pay no more than $35 a month for a 1-month supply of insulin. So that's a great new protection. Also, all ACIP recommended adult vaccines have to be covered with no out-of-pocket. ACIP is the advisory committee to the CDC, and it makes recommendations. So the COVID vaccines are ACIP recommended vaccines, but also the flu shot, tetanus booster, things like that. So those vaccines, if recommended by the Advisory Committee on Immunizations, must be covered with no out-of-pocket. But there are even more protections being phased in over the next 2 years. In 2024, beneficiaries won't pay any cost sharing above the catastrophic benefit threshold. The Part D plans have this complicated donut hole that was built into them. It's been narrowing over time, but basically you pay a certain amount before you hit the donut hole, you pay a different amount in the donut hole, and then a third different amount on the other side of the donut hole. So the thresholds are roughly 4,600 and 7,000 or something, 4,600 to enter the donut hole, 7,000 to exit. After 2024, you won't pay anything past the catastrophic level. And even better, in 2025, Medicare beneficiaries in Part D plans will have their out-of-pocket for Part D drugs capped at $2,000 a year. That is a hugely better than the existing set of rules for people who require high-cost Part D drugs. Again, not your bleeding disorder products, but if you have HIV meds, heart meds, and eye drops, things like that, those fall under Part D, and this $2,000 cap on your out-of-pocket will go into effect in 2025, and it will even allow for spreading those payments out throughout the year, so you're not faced with it all at once in January. Next slide, please. So I kept saying we were going to come back to Medicare Advantage. So we were going to go back to our initial decision point again. And this time we're going to explore that green pathway of what happens if you don't want to go with original Medicare plus the Medigap plus the Part D. What if you want to go with a Medicare Advantage plan and get your Medicare coverage that way? So next slide, please. So Medicare Advantage plans, again, sometimes called Medicare Part C, are, again, benefit packages that are administered by private health insurance plans rather than the government. Basically, the government assigns your Medicare benefit to a private health plan selected by you that manages your care. And just like the different kinds of health insurance plans that Louise talked about in your pre-retirement years, a Medicare Advantage plan might look like an HMO, it might look like a PPO, might look like a special needs plan. Those tend to be for defined conditions. Medicare Advantage plans can offer extra benefits, but the real trade-off is that they also typically require you to stay within a very defined network of providers. Another difference between Medicare Advantage and original Medicare is there is a cap on your out-of-pocket spending for Part A, hospitalization, and Part B services, but the cap can be as high as $8,300 a year for in-network and over $12,000 for in and out-of-network services in 2023. And your Part D drug spending doesn't even count towards that. Now, most plans have out-of-pocket caps below this upper limit, but the caps can still be high. The average out-of-pocket caps in 2022 were almost $5,000 for in-network and over $9,000 for combined. So there is a cap, but it's high. Next slide, please. So depending on where you live, multiple plans may be available. Again, this sounds like the ACA marketplace where you live determines what your choices are. And in this case, you don't go to healthcare.gov, you go to the medicare.gov, and they have a plan finder. Zero premium plans do exist in Medicare Advantage, though enrollees still have to pay the monthly Part B premium. So again, that $165. Coinsurance and copays do exist in Medicare Advantage. So once again, we really urge you to look beyond the premium and make sure that the out-of-pocket costs are sustainable. Don't just be lured in by the zero premium if the costs that you will have to pay to use your insurance are unsustainable. Medicare Advantage coverage plans will cover Part B, as in boy, drugs. So that's your bleeding disorders products. But again, even in Medicare Advantage, the Part B drugs typically have 20% coinsurance. The difference is there is a built-in cap eventually, but that cap may be high. And then Part D drugs, the pharmacy counter drugs, will have copays depending on their tier. Because Medicare Advantage does limit you to a defined network, you really need to check that your providers are in network. So if you're interested in Medicare Advantage, you're going to check that your providers in network. You're going to compare the copays, the out-of-pocket maximum, as well, and the additional benefits, which may be appealing. And again, Medicare.gov has this Find a Plan feature on the website. Next slide, please. So how do you make this choice? You're at the inflection point. Do you have original Medicare or you have Medicare Advantage? We can't tell you how to make that choice, but I can tell you some factors that you may want to weigh. So with respect to coverage, both cover hospital services and medical outpatient care, including bleeding disorders and injectables. Medicare Advantage plans have to cover the services covered by original Medicare. And Medicare Advantage may also cover additional services. It may cover the vision, hearing, and dental benefits that are missing from original Medicare. Out-of-pocket costs are really important. So in original Medicare, remember, there are no limits on your potential out-of-pocket exposure unless you add supplemental Medigap coverage. So as a person with a bleeding disorder, if you're in original Medicare, you will need supplemental coverage unless you qualify for Medicaid by virtue of your income, and that's pretty low level. Medicare Advantage plans do have a limit on yearly out-of-pocket costs, but that limit may be high. And Medicare Advantage enrollees can't buy Medigap to cover that out-of-pocket exposure. Medicare Advantage and Medigap can never be combined. For prescription drugs, original Medicare does not cover most drugs. It doesn't cover your pharmacy counter drugs, though it does cover your bleeding disorders products. So enrollees in original Medicare are almost certainly going to want to get a separate Part D plan to get coverage for your drugstore drugs, whereas most Medicare Advantage plans include the Part D benefit in the plan. Doctor and hospital choice, again, is an area of difference. With original Medicare, you can get care from any doctor who accepts Medicare, but most Medicare Advantage plans are going to limit provider networks and require prior auth before you can see a specialist. So, those provider networks can and do change from year to year. So if keeping your HTCs in network or other key providers, you need to check every year that they are still in network. Your plans for your retirement have to weigh into your decision making. In particular, if you're planning to travel a lot in retirement, or maybe move between a cooler climate and a warmer climate at different times of year. Original Medicare and Medigap may provide more flexibility, again, because of that limited network of providers in Medicare Advantage. And really, really key, think about how your needs may change over time. There are some reports that say that younger retirees really like the extra benefits in Medicare Advantage, but then find that the plans do not meet their needs as well as they get older and develop more complicated medical conditions. And at that point, it can be hard to change. Next slide, please. So that's a lot of complicated information. What are some key takeaways? One is that deadlines are important. If you don't sign up for Medicare benefits on time, you may end up paying penalties in the form of higher premiums that continue for the rest of your life. So the enrollment window begins 3 months before you turn 65. If you want your coverage to start as soon as you turn 65, you need to enroll at the early part of your enrollment window. But if you're still employed or you have a spouse who's still employed and you are covered by credible coverage, then you may be in a situation where you can safely postpone enrolling in Medicare. The details really matter. And so check with your HR department or your local Social Security office or Medicare office. Take the long view. Think about what you'll need, not just this year, but as you age. Again, because some of the choices that you make in Medicare are hard to change once you've made them. It can be hard to switch from Medicare Advantage back to original Medicare plus Medigap, because Medigap plans, once you're outside your initial window of eligibility, can start doing medical underwriting, which means they charge you more or turn you down based on your health condition. And again, taking the long view means you're going to hit those windows of enrollment when you're first eligible, so you don't pay penalties for the rest of your life, which just seems like a real trap for the unwary. Next slide, please. Make sure you are protected against potentially ruinous out-of-pocket costs, including uncapped coinsurance for your bleeding disorder medication. So if you're in original Medicare, you need supplemental coverage. That's either Medigap coverage, or if you are eligible based on income, some of the governmental public insurance programs, Medicare, Extra Help, Medicare Savings Program. Charitable nonprofit assistance is available, but please be aware that the manufacturer copay assistance that Mark talked about cannot generally be used in Medicare. So if you've been relying on manufacturer copay assistance, you will not be able to continue relying on that. And You can get knowledgeable help in navigating your Medicare options. Your HTC social worker, your HR department, particularly if you work for a big firm, and each state runs free, unbiased state health insurance assistance programs. They go by different names based on the state, but you can find all of them at shiphelp.org. Next slide, please. I'm going to go through this very quickly because I think our Zoom link may go away at 8 o'clock. If you are already enrolled in Medicare, we are right now in the Medicare open enrollment period. It runs every year from October 15th through December 7th. And during this period, existing Medicare enrollees can make some changes in their coverage. You can switch from original Medicare into Medicare Advantage. You might be able to switch back from Medicare Advantage to original Medicare, but beware of your ability to get Medigap. If you are already in Medicare Advantage, you can switch from one plan to another. Similarly, you can switch from an existing Medicare Part D prescription plan to another Part D plan. Next slide, please. What you can't do in the fall open enrollment period is use it to enroll in Medicare if you missed your initial window of eligibility. There is instead a separate Medicare general enrollment period, which starts in the new year, and you can sign up then and your coverage will be a little delayed. You also can't use the fall open enrollment period to sign up for a supplemental Medigap coverage. Again, the best time to sign up for a supplemental Medigap is when you first become eligible for Medicare. In the 6 months following that initial enrollment period, you can apply at any time and the Medigap carrier has to accept you. After that period, in many states, the Medigap carrier can turn you down or vary your premiums based on your medical history. Some states do have more protective rules, and that is something you could check with your state health insurance assistance program, the SHIP. I will say just one last word about SHIPs. They're a great resource. They're not going to be experts in bleeding disorder care. So this is a great resource for you to bring your own education and, among other things, knowing about that importance of Part B coverage and protection against Part B cost exposure. Next slide, please. So to close with some tips, this is a theme you've heard throughout the evening. Actively review your coverage. If you're already in Medicare and we're in the middle or nearing the end of open enrollment, review your coverage. Medicare plans do change their costs, they change their formularies, they change their networks every year, and your needs may change too. So make sure that you've still got a good match between your plan and what you need in terms of drugs, healthcare providers for the coming year. And again, remember that a low monthly premium is not always the best overall value to meet your needs. Take a look at the full picture, including deductible and other out-of-pocket costs. Next slide, please. And that is it. I don't know if there were any questions that came in during the, okay. There was a question about will Medicare be affected by the unwinding of the public health emergency? And the answer is that actually there is a federal rule that provides some protections exactly for that. Remember I said that hitting those windows of eligibility is really important, and you may pay a penalty if you miss it. There was some leeway built in for people who find themselves disenrolled from Medicaid, or they've been on Medicaid throughout the public health emergency, and there's a little more leeway for them to make that transition from Medicaid to Medicare without paying a penalty. But I still urge you, to the extent you can, please observe those windows. Let's see. Questions. What if I qualify for Medicaid and Medicare? That is absolutely a thing, and Medicaid will end up picking up a lot of your costs. They pick up some of the premium for your Part B coverage. Remember, most people don't pay a premium for Part A. Most people do pay a premium for Part B, but Medicaid can pick up the premium and can also cover co-pays and co-insurance, but there's quite a low level of eligibility. I think it's something like 18,000 for in a year in income for a single person.